So as usual, we're just going to wait a couple of more minutes. In the meantime, we have our beginning slides where you can see information on our clinical patient management system. As in today, we have launched our new version of CPMS. So everybody is able to get access into CPMS 2.0, which we are very excited about. So feel free to read the information on how to upload a clinical case onto the system. If you have any questions about the new system, you can contact us via email.
Welcome to the EUROGEN webinar programme. I'm Michelle Batty, the manager of the European reference network that we call EUROGEN. EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017. And they all deal with patients with rare diseases and complex conditions that need highly specialised treatment. And in our ERN, we deal with rare urorectogenital diseases and complex conditions that all need highly specialised surgery. So really where the expertise is rare. And we're currently a network of 56 healthcare providers in 20 member states, all working together to improve care for our patients. So what does an ERN do? Well, some of our activities, I hope you saw from the beginning slides, one of them is that we conduct secure cross-border virtual consultations. So any healthcare professional working in any hospital in the EU can contact us if you'd like the advice of our network of experts. And this is free of charge. So please, we have the new system now. I would strongly encourage anyone with a tricky case to please feel free to get in touch. We'd be delighted to help. We also collaborate on training and education activities. We write clinical guidelines on the disease areas covered by our reference network. And another very exciting area is we're developing a EUROGEN patient registry. We all know that data on rare diseases is fragmented and scattered across different countries in very small sizes usually. So we hope by pulling together this long-term sustainable registry funded by the European Commission that over time will gather more evidence for the clinical guidelines that we're writing, and also we'll be able to identify important research questions that are still without answers. So finally, we have the book, the EUROGEN book, so published by Elsevier. So it's the latest scientific knowledge from our network on rare and complex urology. So without further ado, this evening's webinar is about outcomes and challenges in spina bifida, bridging adolescence and adulthood. And we're extremely honoured to have our speaker with us here this evening, and it's Niklas Pakkasjärvi, and he is a paediatric urologist consultant. He's associate professor at Helsinki University Hospital at the Department of Pediatric Surgery. So, Niklas, we're incredibly grateful to you for sharing your expertise with us this evening, and I hope everyone enjoys the webinar. Please do ask questions at the end. Thank you.
Good afternoon, everyone, and welcome to today's webinar titled Patient-Reported Outcomes and Urological Challenges in Spina Bifida, Bridging Adolescence and Adulthood. My name is Niklas Pakkasjärvi. I have no financial disclosures. I work in the New Children's Hospital in Helsinki at the Department of Pediatric Surgery, section of Urology, part of Helsinki University Hospital. I'm a member of the EU Pediatric Urology Guidelines panel. However, this presentation is from the standpoint of our institution. I have a tenure-track professor's position at the University of Turku and Vaasa Central Hospital. The new Children's Hospital of the Helsinki University Hospital serves as a tertiary pediatric urology center, catering to the region of southern Finland, which accommodates approximately 2.2 million inhabitants. In addition, certain conditions are officially centralized to our hospital, and further, we provide expertise for the 4 other university hospitals in the country. In managing spina bifida, the well-being and equality of patients and their families are foundational to providing comprehensive care. Beyond addressing medical challenges, such as bladder and bowel dysfunction, this approach recognizes the broader social, emotional, and practical needs of the patient and their support system. By ensuring families are equal partners in care and prioritizing their unique perspectives, we can create a supportive environment that fosters independence, resilience, and a better quality of life for individuals with spina bifida at every stage of their journey. While the classification of neural tube defects, including spina bifida, have evolved, this presentation addresses spina bifida in general, with the majority of patients classified as myelomeningocele without further distinction. For a detailed classification, we encourage you to view the ERN eUROGEN webinar on spina bifida. In addition, the ERN collection contains excellent in-depth data on various aspects of spina bifida. The data presented in this presentation is from the viewpoint of our institution. We have a volume of around 45 patients with neurogenic bladder of spinal origin. However, the yearly volume of newborn patients with especially spina bifida seems to decline. We base our treatment regimens on the evidence-based EAU pediatric urology guidelines, from which we have modified our own operating protocols according to local characteristics, resources, and needs. Our hospital exemplifies a university hospital as we research and educate in addition to execute clinically. We have a strong research orientation, and through our Pediatric Research Center, which bridges research and clinics, we network with many universities. This presentation is also built around our research results. All clinical data presented here are from research done by Professor Seppo Taskinen. While our volumes are rather limited, common to all Nordic countries, follow-up of patients is of high standard with high attendance rates and reliable investigative methods. This enables high-quality research. All patients stay within public health services despite of moving to other districts. Further, we have a proper and good functioning network among colleagues so that patients are discussed together irrespective of their residence with uniform treatment routines. In addition, courtesy of established transition services, follow-up after transition to adult healthcare is standard. To that end, let's proceed to patient outcomes and what challenges they face and how we as pediatric urologists should embrace this holistically. I will share insights from both the published literature and from our own results, which highlight the complexity of spina bifida care across different life stages. Spina bifida is a congenital condition with significant urological and quality of life challenges, especially as patients transition from pediatric to adult care. Advances in treatment have successfully mitigated risks like renal failure, but persistent issues like incontinence continue to impact daily life and long-term well-being. Historically, renal failure was a leading cause of mortality in individuals with spina bifida. The underlying issue was often poor bladder management, leading to high intravesical pressures, hydronephrosis, recurrent urinary tract infections, and subsequent renal damage. At the time, bladder dysfunction often went undiagnosed until significant kidney damage had already occurred. Over the past decades, advances in medical and surgical interventions have significantly altered this trajectory. The advent of clean intermittent catheterization in the 1970s and its widespread adoption in the decades that followed marked a turning point. CIC allowed for effective bladder drainage, reduced high pressures, and minimized the risk of infections. Combined with anticholinergic medications, these interventions significantly improved bladder compliance and helped maintain renal function. As a result, the focus of morbidity has gradually shifted from renal failure to incontinence and infections, which, while less life-threatening, poses considerable challenges to quality of life. Today, proactive management strategies have further improved outcomes. For evidence-based practices, please familiarize yourself with the EAU guidelines on pediatric urology, found both online as printable PDFs and recently introduced as an app for your smartphone. I will not go through these flowcharts in detail here, but these are rather self-explanatory. They include guidelines for each age groups. Common to proactive management strategies is the understanding of the detrusor-sphincter relationship status. For instance, urodynamic studies, introduced as a standard diagnostic tool, enable early detection of high-pressure bladders and guide interventions. Treatment begins in infancy with a focus on preventing small, non-compliant bladders that could lead to upper tract deterioration. By the time patients reach adolescence, most are on a regimen of CIC and anticholinergics. In our hospital, CIC is started early, and patients undergo urodynamic studies within the first months of life. Anticholinergic medications are prescribed for suspected detrusor-sphincter dyssynergy. Subsequent treatment is modulated according to urodynamic follow-up findings. In cases of overactive bladder or suspected detrusor-sphincter dyssynergy, urodynamy is performed on a yearly basis, and in cases with normal volume, low-pressure bladders less frequently. In addition, a urodynamic study is always performed prior to any surgical intervention, or if the surgical intervention did not improve incontinence. Our primary treatment goal is the prevention of small high-pressure bladders to prevent hydronephrosis and to treat incontinence. Patients who do not respond to anticholinergics are administered Botox as a secondary treatment, and those who fail to respond to this regimen are presented with bladder augmentation. Due to our small volumes, we can maintain a rather personal, patient-stratified treatment approach, as our resources are not challenged by the patient numbers. To detail the results of our treatment protocols, we retrospectively reviewed urological outcomes of our research protocols. At their last follow-up visit to our hospital at the age of 15 years or older, in a cohort of patients with myelomeningocele born between 1985 and 2005, 55% were ambulatory. 67% of whom required no supportive device, while 45% of the patients from the whole cohort were wheelchair users. The median age at the last hospital control was 18 years. Among this cohort, 93% of patients were enrolled in a CIC program, and 83% received treatment for an overactive or poorly compliant bladder. Half of the patients used anticholinergic medication, a third received Botox, a third had undergone bladder augmentation. Through this proactive treatment protocol, 100% presented with normal serum creatinine levels at their last follow-up visit. At the end of the study, 55% were fully continent, 18% experienced occasional incontinence, and 26% were incontinent daily. Notably, the incontinence episodes in many patients consisted solely of droplets. 6% of the patients did not require any specific urologic treatment. To summarize, nearly all patients utilized CIC and 85% received treatment for reduced bladder size. A significant proportion of the patients underwent surgical intervention, with a third undergoing bladder augmentation and almost half bladder neck procedures. Given that all patients had adequate bladder capacity with low pressures, incontinence was presumably due to an incompetent sphincter, despite that more than half of the patients having undergone bladder neck procedures. In some instances, non-compliance with regular CIC was a significant reason for incontinence. We found no association between patient characteristics, treatment approach, and continence. Our findings underscore the necessity for patient-specific management and vigilant follow-up. We acknowledge that our cohort presents with a high proportion of surgical interventions as compared to the literature. Nevertheless, none of the cohorts are directly comparable to ours as far as we can deduce from given data. Proactive treatment preserves renal function. However, despite this and extensive surgical interventions, incontinence remains prevalent in adults. In our study, only 55% of the patients were fully continent. This aligns with other studies. In a large registry-based study, only 44% of 18-year-old patients with myelomeningocele were found to be continent. Additionally, two systematic reviews analyzing data from a total of 4,400 adult patients with myelomeningocele reported a combined continence rates of approximately 48%, highlighting the persistent challenges with incontinence in this population. Furthermore, in an online study, 76% of patients reported some degree of urinary incontinence, which was strongly associated with a lower health-related quality of life. Among our patients, hydrocephalus or wheelchair dependency were not associated with more prevalent incontinence. Given that all patients have adequate bladder capacity with low pressures through proactive early treatment, but the patients are still troubled by incontinence, it presumably is due to an incompetent sphincter. The approach to the management of sphincter insufficiency is multimodal in our institution. To de-annihilate bladder neck procedures in bladder-augmented patients, we retrospectively analyzed patients who had undergone enterocystoplasty because of neurogenic bladder who presented with sphincter insufficiency. Our treatment strategy for sphincter insufficiency starts with bladder neck injections up to 3 times, given that the patient does not present with very difficult incontinence or a very wide bladder neck, and the first injection gives some response. The patients are offered a sling procedure if bladder neck injection is insufficient, or the bladder neck is very wide, or the incontinence is very difficult. We attempt to avoid bladder neck closure whenever possible. We did not perform bladder neck reconstructions in this series. We could not detect differences in the necessity of bladder neck procedures among patients with different diagnoses or sex. However, diagnoses other than myelomeningocele were too rare, hindering statistical analysis. With our strategy to treat incontinence due to sphincter incompetency, partial or total continence was reached in 95% of patients. We conclude that the treatment of sphincter insufficiency after bladder augmentation is challenging in patients with neurogenic bladder. In the care of patients with spina bifida, it is often straightforward to focus on surgical and physiological aspects, especially in the early years when the goal is to preserve organ function and address structural issues. These proactive measures, guided by tools like urodynamic studies, are critical for preventing long-term complications, such as renal failure. However, as the patients grow, their needs extend beyond the physiological. The importance of understanding and integrating patient perspectives becomes increasingly central to decision-making. Factors such as quality of life, mental health, social integration, and individual preferences play a pivotal role in tailoring care to each patient. This shift highlights the need for a balance, acknowledging the practical necessity of medical interventions while ensuring decisions align with the patient's lived experiences and long-term goals. By embracing both perspectives, we can provide care that is not only effective, but truly patient-centered. In pediatric healthcare, the patient experience must be rooted in principles of children's rights, as outlined by the Nordic Network for Children's Rights and Needs in Healthcare. This framework emphasizes the importance of respecting each child's dignity, providing age-appropriate communication, and ensuring family involvement. By prioritizing these rights, we create a supportive and inclusive environment that minimizes stress, enhances understanding, and empowers children to actively participate in their care. These principles are not just ethical guidelines, they are essential for delivering holistic and patient-centered care in line with the needs and perspectives of our patients. Patient-reported outcome measures give patients the ability to convey their symptom burden and health-related quality of life directly from the patient. Despite a considerable body of research on urological outcomes in spina bifida, a gap exists regarding patient-weighted outcomes, and especially on what tools to use for understanding the patient perspective. Studies by Szymanski et al. And Olesen et al. Show how urinary incontinence negatively affects quality of life. Interestingly, while CIC thus is helpful, quality of life in these patients seem unaffected by the route of catheterization, as discussed by Hirsch et al., who in their recent analysis highlighted these issues. These findings highlight once again the importance of individual tailored treatment programs. A commonly applied patient-reported outcome measures tool is the Pediatric Global Health Standardized Questionnaire. It measures general health across physical, mental, and social domains. The Neurogenic Bladder Symptom Score evaluates bladder-related symptoms and their impact. The Brief Health Literacy Screening Tool and the Transition Readiness Assessment Questionnaire can help us in understanding the need for educational support. Transitioning of patients toward adult healthcare presents significant challenges, which in many instances lacks structured processes. This is a stage which may lead to gaps in care and thus poorer health outcomes, and is not only limited to physician-patient interaction, but can manifest as problems in medical record transfer and other pragmatic issues to deal with. In many hospitals, regions and countries, transition from pediatric to adult healthcare occurs around the 16 to 18-year mark. While children without disabilities may advance towards independence at this stage, individuals with spina bifida may still be far from that transition from many aspects. Therefore, transition programs are essential for not only this patient category. Patient-reported experience measures alongside patient-reported outcome measures could provide a more thorough view of the patient perspective during this sensitive period. However, we must not drown the patient with questionnaires. Up to 40% of the patients require caregiver assistance in completing such, which naturally introduces bias to the answers. And the more questionnaires we give, the lower response rates we end up with, further complicating the interpretation. Thus, we must strive for a comprehensive picture through a selective use of tools which are, just like treatment, individualized for the specific patients, their needs, and circumstances. While proactive treatment protects the kidneys and also helps improving incontinence, problems beyond quality of life issues may emerge. In evaluating additional surgeries for patients having undergone enterocystoplasty, this retrospective study shows that 1/4 of patients had undergone surgical treatments due to augmentation-related complications. The most common complication was bladder stones, which occurred in almost 1/5 of the patients. In addition, obstructive ileus, undersized bladder, bladder perforation, and a lobulated bladder were also treated. Patients with bladder augmentation are also at risk of osteopenia and compression fractures, but these risk factors are mostly related to the patient's underlying illness and not the augmentation per se. Importantly, bladder augmentation at school age has no adverse effects on longitudinal growth. While mortality rates in spina bifida have declined, as shown in this study by Anderson et al., in adults, additional mortality factors were bladder malignancy, self-inflicted injury, and substance abuse with possible suicidal intent. This warrants regular screening for depression and anxiety. The increased risk of fatal bladder cancer should also be recognized, and symptoms should prompt a cystoscopy without delay. In managing spina bifida, the focus of care evolves significantly as patients grow. During infancy and early childhood, the emphasis is primarily on proactive management and surgical interventions. At this stage, the key priority is safeguarding the patient's health through measures that prevent complications, such as renal failure. Proactive use of urodynamic studies to identify high-pressure bladders, along with timely interventions like clean intermittent catheterization, anticholinergics, and surgical procedures, is essential for preserving renal function and preventing upper tract deterioration. However, as patients approach adolescence and adulthood, the emphasis begins to shift. While maintaining physiological stability remains important, the patient's quality of life, independence, and individual preferences take center stage. This is a critical period where patient-reported outcome measures become invaluable. These tools allow us to capture the nuances of each individual's experience, addressing issues like mental health, continence, transition readiness, and social integration. By understanding the patient's perspective, we can move from a primarily intervention-driven approach to one that focuses on personalized, holistic care tailored to their needs as they transition to adult life. In essence, the care pathway begins with a focus on surgical necessity and evolves into understanding and supporting the patient's journey toward a good quality of life. This shift is not a replacement, but a progression, balancing proactive medical strategies with individualized, patient-centered goals. We are approaching the end of this presentation, and we would be happy to entertain any further questions that you would have. Thank you for your attention.
Great, thank you. I would like to open up the discussion section of the webinar. So if you have any questions, feel free to type them in. You have a Q&A section somewhere down below with a question mark, so you can find that and it pops up so you can type in your question. You can also raise your hand and then I can open up your mic so we have a live case discussion if you like. Have you found any features that make BNI more likely to be successful? They haven't had good success with it, so they don't often bother using it.
Well, the bladder neck should not be too wide. And then we also try to assess the response of the injection, but that's not always so straightforward.
So it's being asked, what would prompt you to recommend bladder augmentation after Botox, and at what point in time after intravesical Botox would you assess?
Oh.
Okay, so beyond continence, with transition to adulthood, we must confess that that's a bit of a work in progress. So we will address that maybe in future sessions. And then the question was, what would prompt you to recommend bladder augmentation after Botox, and at what point in time after intravesical Botox would you assess? Well, it of course depends on patient characteristics and what's the response to Botox and sort of the whole picture. We also have our other colleagues here, Eija and Seppo, which I forgot to introduce, who have been central in making this presentation.
I believe then that was it. So thank you very much for this evening. I've said everything I wanted to say, so I will close this session and I will see you all at our next webinar. Have a nice evening.